we take a clinical scenario, this is very common to us that there are many scenarios that we see. With this cardiology audience here, I'd say that we see a much older spectrum of patients that present to our hospital. Let's say here's a 45-year-old advertising executive, presents with vomiting of dark red blood. For the last 3 days, he's had a bit of melena, felt lightheaded and faint at work, and he was brought by colleagues to the hospital. And he gives a history of dyspepsia, which many people in this country describe as gas trouble. In fact, gastroenterologists, where I was in my previous incarnation in Vellore, we used to be called gastrologists. This is, everything is passed off as gas trouble. He is a heavy smoker, hypertensive, on treatment with metoprolol. You can see a type A personality. So when he was brought to emergency, he was pale and anxious with a pulse rate of 96 per minute, and I'll make a special mention of the pulse rate because this person has been on metoprolol, and so that will always reduce the pulse rate, and so you might have a false sense of security when you say, okay, he's not too tachycardic, and therefore maybe he doesn't have a major blood loss, but anybody on beta blockers would already have a reduced heart rate. This applies for people over the age of 60 or 65, that they would have a low heart rate, but still they may have lost a significant amount of blood. Physically, so blood pressure here shows systolic pressure of 90, which again signifies significant major blood loss. At least over 20% of the blood volume is lost. Abdominal examination showed epigastric tenderness. Of note, he had no guarding or mass. If he had guarding, then you'd also think in terms of things like perforation and so on, a major emergency or an ischemic bowel disease. His hemoglobin when he came was 7 grams, so he's lost a significant amount of blood in the last 3 days. Normocytic anemia, coags normal, creatinine normal, urea is mildly elevated, which suggests that he has a pre-renal azotemia. Chest X-ray and abdominal X-ray were normal. So in history, the items which are of importance are long-standing dyspepsia, history of alcohol, liver disease, NSAID use. I'm saying this basically because it's a mixed audience, so some of the cardiologists would have forgotten what they do with upper GI bleeds. So past history of surgery. In our current day, at least in the hospital that I work, we see a lot of people who've been on platelet inhibitors and anticoagulants. I suspect that many of us working in Chennai see this. So a lot of them come with upper GI bleeds. It's strange that in this city, at least in every area, there are no real units that work in a coordinated fashion, or there's no upper GI bleed center. So coming back to this, just to remind you, hematemesis usually means that the bleeding has occurred above the ligament of Treitz. So it's usually from the duodenum or above. If you have hematemesis, you don't need to go chasing a lower gastrointestinal cause. On examination, essentially what we were taught, if you find abdominal tenderness, think of peptic ulcer. If you find a mass, think of carcinoma, although just as nowadays something that we see. If you find splenomegaly, then it's portal hypertension. So I think these kind of rules still hold good. So just a quick examination in emergency is something that we always teach our colleagues. So when this patient comes to emergency, the questions that come to the mind of the treating physician is, how severe was the bleed? Does the patient need hospitalization? What is the cause of the bleed? Is there a need for urgent endoscopy? And is surgical consultation indicated? And just to look at some of these. If there is no tachycardia and if the blood pressure is normal, then the blood loss is minor. So it's less than 10%. If the pulse rate systolic, the pulse rate is greater than 100, and if there's a postural hypotension, fall in systolic pressure greater than 10 millimeters standing or sitting, then it signifies a 10% blood loss. Supine systolic blood pressure less than 100 signifies a 20% but greater blood loss. Just to remind you that bleeding can be variceal or non-variceal. That's how typically we would approach it. Let's forget epidemiology. So there is a twofold higher incidence in males than in females. The causes are many. We all know that with the older age group, you can have bleeding from esophagitis. With alcoholics, you can have bleeding from Mallory-Weiss tears. Cancers, ulcers, and varicose bleeds are common. And particularly in people who've undergone any kind of aortic surgery. Again, I say this because I come from a center where we have specialists in aortic surgery. So there we have aortoenteric fistulas. And one of the unusual cases that we've seen is actually a metastatic tumor, an rhabdomyosarcoma in the aorta with a metastasis to the liver. This guy bled like a fluid. So when you look across the spectrum in India, so whether it's in an urban center in Delhi, an urban center in Chennai, or a rural coastal Odisha, the commonest cause of upper GI bleed seems to be ulcers and not varices as many people think. So ulcers followed by erosions and varices seems to be the trend in many places. If you're in a specialist center, you'll see many more varices. Particularly if you're dealing with liver disease and doing transplants, then I guess you tend to see more varices. So typically, one uses a kind of scoring system, a very simple scoring system. This is shown here is the Rockall score, which you use to say when emergency endoscopy may be indicated. So what these signify is that if somebody is less than 60, doesn't have shock, has no other comorbidities, and has no active bleeding, then this person is unlikely to have a recurrent bleed in the immediate future. This person can be safely discharged home after observation for a few hours, does not require emergency endoscopy. The Scottish Intercollegiate Network actually recommends that anybody with a Rockall score greater than 1 should undergo endoscopy within the next 24 hours. I would say as a practicing gastroenterologist and probably many of my colleagues here, that I feel comfortable if I scope them in the night, because I don't want to sit on somebody who is a time bomb and deteriorates over the night. So the management approach is to resuscitate, use white bore needles, do all the blood chemistries, the blood tests that you need, look for risk factors and comorbidities, do an early upper GI endoscopy. The use of a nasogastric tube is advocated in many of the guidelines which you see, but personally I believe that early endoscopy does away with the need for leaving in a nasogastric tube. Although if there is continuing bleed, it helps to have an NG tube in situ to know if your treatment has succeeded or failed. And then the treatment is endoscopic, pharmacological, or surgical. Again, I won't go through this. It's the role of nasogastric lavage and all that would be in hospitals which don't have access to immediate endoscopy. So the pharmacological management is for variceal bleeding is with octreotide and terlipressin, and typically this is done basically if the consultant doesn't, or the person on call doesn't want to come at night to treat and bleed immediately endoscopically. Because I still believe that endoscopic hemostasis is best. And these other measures are used to temporize. So giving octreotide and terlipressin. Surgical management and including radiological management like PICS, we can talk about for variceal bleeding. So non-variceal bleeding is really what we see most. And here there's pharmacotherapy with intravenous proton pump inhibitors, endoscopy and surgery, blood transfusion, typically to keep the hemoglobin around 7 to 8. Particularly in variceal bleed, we try to avoid over-transfusion. And for patients with pre-existing cardiovascular disease, which is a population that we increasingly see, we would try to keep the hemoglobin a little bit higher. The proton pump inhibitors, we have a variety, and since we are in iamicon, I am going to talk about rabiprazole, which the IV rabiprazole, which the Gorilla has developed. And so that is given in bolus dose. Typically, most hospitals use pantoprazole. In the UK, most hospitals use omeprazole in ICUs, and esomeprazole is used, I think, widely in many other places. So typically, you would continue intravenous proton pump inhibitors for 72 hours and switch to oral PPI if there is no repeat. The reason for using PPIs is essentially because if the pH is low, the clot lyses. And by maintaining the pH above 4, you can reduce clot lysis and thereby prevent early rebleeding. We won't go through this. This is basically saying it again. And so the consensus recommendations say use IV PPIs in all patients, even post-endoscopic therapy. This is something that we use by standard. We've talked about this, the Scottish Intercollegiate Guidelines Network, which recommends high-dose IV PPI. And high-dose IV PPI, so about intravenous rabiprazole, a wireless pH study shows that it is very rapid in terms of reducing the acid. So in this particular study, again, this was presented by one of my former students, I think, Arun Basi in a World Congress. So rabiprazole, much more rapid than pantoprazole or omeprazole. Shown here is a pH monitoring, and the pH stays high. And what was they further shown using this pH monitoring is that a bolus dose is as good as a continuous infusion. Endoscopic therapies, of which the most commonly used is injection sclerotherapy with diluted adrenaline, 1 in 10,000, 4 quadrants around the ulcer. This is the easiest to do. Where we have the equipment, then it will be good to use heater probes, particularly which are useful for coagulating visible vessels in the base of the ulcer. Hemoclips are also increasingly used, and that's something, in fact, very often we use 1 or 2 of these modalities together. More than 2 of these modalities are likely, but at least 2 of these modalities together. The second thing to remember in somebody that we've done an endoscopic intervention is that I have found that I would really like to go back 24 hours later inside just to see that we have continuing hemostasis. I won't go through, I mean, I had some videos here, but I'm not going to talk about that. So essentially, endoscopy is good for diagnosis. We need for diagnosis. We can identify the lesion and we can treat the lesion. And we've already specified that it's recommended for a full assessment in patients with a Brocard score of 1 or greater. We can classify ulcers when we look at them based on the Forest classification, and based on whether there is a pigmented spot in the base, whether the base is clean, whether there's a visible clot, or whether there's active spurting, we know the risk of rebleeding varies according to that. And this is good for prognostication for patients with a clean base. If you do an urgent endoscopy, even in emergency or soon after they come to the emergency, you can send them home because without any hesitation, because you know they're not going to bleed again in the next few days. So surgical management. So typically somebody who is really who is in shock, I would prefer to take them to the recovery, which is attached to the theater. endoscope them there and alert the surgeons, endoscope them there, and if endoscopy fails to control it, which we've seen this with some spurters, that you take them immediately to surgery. If there's, obviously, if there's continuing bleed, or if there's failure of medical and endoscopic therapy, or if there is an associated problem like perforation or obstruction, then surgery is the choice. The algorithm, I think I've basically dealt with this here. Typically, we would aim for quick discharges in these patients. Cardiac patients are a very vulnerable population. We see a lot of them now because of the amount of interventions which are done. So advanced stage, high comorbidity, the fact that they are both on their dual antiplatelet therapy, including aspirin, and the fact that they may have some pre-existing mucosal defects makes them a very vulnerable population. The only issue, since we have some cardiologists here, if somebody has a bleed and has been on dual antiplatelet treatment, then the issue of restarting antiplatelets comes in. So if they are on low-dose aspirin for primary prevention, then we would recommend that you do not resume aspirin. If they are on secondary prevention, you can resume aspirin soon after controlling the bleed. And in most cases, in these patients, if they have H. pylori associated ulcers, if we treat the ulcers, the chances of recurrent bleed are greatly reduced. So with that, I'll end. Thank you.
So can we have one question for the day? I think we are running a little bit behind schedule. So anyone from the audience have questions for? Okay, sir.
Ramki, when was the last time you referred a case to your surgeon?
My surgeon is sitting here. I'll have to ask him.
No, I'm asking you.
About 2 months back.
Okay. Here we have an answer about 2 months. We work in close coordination.
What was the indication?
Again, I'll have to look to you for that.
It's only your word.
There's a gastric ulcer bleed. It's quite a big ulcer and couldn't be controlled by clipping. So we had taken up in the middle of the night and do excision of the ulcer.
So actually the last one that I remember was an aortoenteric fistula. He's a physician, 80 years old. And cardiothoracic colleague. I mean, we were all involved in it. Dr. Radhakrishna was involved in the surgery. Dr. Bashi did the surgery. He actually went in and repaired the fistula. We had to open up. I mean, we tried things. Nothing worked. It was a graft which was bleeding into the from the descending thoracic aorta, which was bleeding into the esophagus.
Sir, when we record as an obscure upper GI bleed, and what are the possible causes?
Obscure upper GI bleed would be rather uncommon because most upper GI bleeds are within reach of the endoscope. And typically when we do an endoscopy, we tend to go, and nowadays with the scopes that we have, you can easily go into the first loop of jejunum. So obscure upper GI bleeds are a little uncommon. If they are there, they will be lower down in the jejunum, and they would obscure obviously can be either overt or occult. And overt is when they have melena, occult is when they present an iron deficiency anemia. Typically that would be a small bowel lesion. And in our experience, jejunal angiodysplasias are probably the most common cause of that.
I really appreciate, but often we see that aortic valve replacements where they are on anticoagulants, stopping even for a day or two, it will clot, clotting will occur over the grafted valves. Then you are in great dilemma. One must be extremely careful. And I want your comment on how many times you fail in doing that one. What is the real mortality in these cases?
Fail in endotherapy?
Yes.
Yeah, we do fail in endotherapy this, for various reasons. So one may be lack of access, one may be that the lesion is too large, but the accessories which we have are constantly improving. And if we have larger lesions, we even have the ability to band them. So failure, maybe about 5% of the time or less.